So yes, I've titled my talk, The Irony of Population Health Management. I'm going to keep you on a cliffhanger for another half hour on that one. What I want to start with today is to share with you our latest release of our Engage patient portal. So this is the latest and greatest version of Engage. It's version 5.12. And I'll go through each of these features in a little bit of detail, but you can see if you are familiar with our patient portal from previous versions, we have added a lot of style and colour to it, and we're trying to go in a direction that makes it much more engaging for our patient population. So you can see here, we've added white labelling and branding. And this runs through the whole platform. So you will pick a set of primary colours and a set of secondary colours, and we can apply the font that your organisation has standardised. So we're now able to align to a lot of different design systems. So whether you've got a corporate brand or a local brand, or you've got a national brand like the NHS, we can apply that colour scheme to it. So spot the difference. On the left here, we have the existing version of the patient portal, and on the right here we have the new natural theme that you will get out of the box when you upgrade before you apply your own colour scheme. So you can see it's a little bit sharper, it's a bit clearer. Hopefully those of you at the back can see that. And as I said, the white labelling aspect actually helps us to align with your brand. So if you have a really strong brand, like I know Connecting Care or my Dorset Care record, you have very strong brands and you've built up trust in those brands over a number of years. You can now add your own flavour to the patient portal. This particular dark blue or bright blue of the NHS is there to represent the trust and the security of the NHS brand. And it just helps tie everything together. So on to self-registration, and one of the things I'm hearing continually as I talk to you is that how do you get, at scale, a lot of people using your patient portal? So we've been working in the last 6 months to put self-registration into the platform. And so what I'll do is I'll kind of step you through how that works today. So traditionally, a clinician or an administrator would invite a patient to sign up for an account by sending them an email. So it's triggered by the clinician. So the clinician would know the patient. They may have a relationship with the patient over a long period of time, and they want to invite that person to get access to their own records. Now with self-registration, the patients can actually, off their own bat, go to the platform. They might see some advertising in a waiting room, for example, or a QR code that they scan, and they can actually come in and sign up on the spot. So the first thing we need to do is actually confirm, are they eligible? And in each jurisdiction we work in, there is differences over eligibility. There may be an age limit, over the age of, say, 18, you're allowed to use it. And then we will want to know their name and their email address. And the very first thing we will do, of course, is tell them, sorry, you can't access it if they're not eligible. But we will also send them an email with a verification code that they will then have to put into the platform so we know they own or at least have access to that email address. And that's really important because actually the next step is checking, are they registered already and they've just forgotten, and I've been in that position myself. And so if that happens, we will actually prompt them to log in using their own credentials, and of course they can do, I know I forgot my username or I forgot my password if they need to at that point. But assuming that they are a truly new user, we'll invite them to choose a username and password, set up a secret question, and then most importantly, accept the privacy policy and the terms of use. And that's where they will understand how their data is going to be used, who's processing it, what safeguards are being put in place to secure that data. And then they'll receive an email. So this is a pretty common workflow that you'll all be familiar with if you signed up to any other kind of consumer website, and we'll tell them, congratulations, you finished the process. Then at that point they'll be invited to actually use those new credentials to sign in. But wait, those of you who are in England will be saying, hang on, what about NHS Logon? How does that fit into the picture? Now, NHS Logon is designed to be one system that everyone can sign up to and then use that identity or that set of credentials to log into many systems. And it's a form of IAM, infrastructure, identity access management. And you will have been used to using this in other websites. So if you've ever used Airbnb, for example, these buttons that say log in with Facebook or log in with Google, log in with Apple, that's IAM. And NHS Logon is a form of IAM. So the next piece of our development roadmap really is to work with NHS Digital and to work with a sponsoring organisation, hopefully one of you, to actually add this capability into the platform so that instead of using your own username and password, you can actually use the NHS Logon if you have one. And I've done this myself. I've gone through the whole process, took the selfie, scanned my passport, logged in, and actually, surprisingly, it was pretty quick and simple. I was quite impressed. But when you actually come to the logons, the self-registration screen, you might be in one of many different buckets. You might be an existing Engage user, you've just forgotten that you were. You might be an NHS Logon user, but not yet an Engage user. You might have no Engage account, but an NHS Logon account, or you might have neither. And so depending on which of these buckets you fall into, you're going to end up taking one of these pathways and then having one of these outcomes. But it's not quite as simple as just using your NHS Logon to create that account, because there's actually 3 different identity trust levels that NHS Logon uses to prove who you are. And the first level, which they call P0, is low trust. And essentially what that means is when you signed up for NHS Logon, all you told it was your mobile phone number and your email address. So you could have actually been impersonating somebody else. I, for example, know my husband's email address and I know his date of birth and I know everything about him. I have access to a shared email account with him, so I could basically sign up for this with his credentials. So it's not necessarily something we'd want to let people into our Engage patient portal with if they've only reached P0. P5 is the next level up. There's actually no 1, 2, 3, 4. It goes 0, 5, 9. And in P5, once you've actually registered, it asks you to tell the system your NHS number and your date of birth. But if you don't know that, it will take you down this other path where you can say, actually, I know my GP details. And the goal of that really is to do a PDS trace. PDS is the personal demographic service to check who you are as a patient. So this is basically figuring out who you are as a patient in the NHS system. P9, however, is where you actually prove who you are personally. So this is kind of analogous to actually having your passport with the photo or your driver's license and proving that it is the real me. And this is the process I went through. I scanned my passport and then I sat in front of the camera and it did this cool scanning thing and it took a selfie. And I had to take my glasses off so I couldn't actually see what was on the screen as I was doing that. It was a bit difficult, but anyway, I got to the end of it and now I am trusted at P9 level. And this is really the level you would need to be at if we wanted to link you to your Engage record, because we know who you are, we can communicate with you over a verified email and mobile number, we know your NHS number, and we can prove that you are who you claim to be. So I couldn't impersonate my husband at this level because I don't have his face. This proves your personal identity. So the next steps for us, we have done a Spike prototype using the OpenID Connect protocol into the NHS Logon sandpit environment. And we've proven that we can get that token from them and create a user account with it. The next step for us is once NHS Digital move out of their beta phase, so they've got a closed beta happening at the moment, we're in the queue to hopefully be next in line to engage with them and engage with you to work through what are those use cases, those buckets of different ways people can come into this process. And thirdly, to agree what's going to happen when we want to give access to patients who have elderly parents that they're managing the care of, or in the case of parents like myself, access to children's records. So in the NHS app at the moment, if you want to delegate proxy access, you actually go and talk to your GP. They record it on their system, that relationship, and then it flows up to the NHS account. But how we actually manage that for a local shared care record, I don't think anyone's kind of thought that through in any great detail yet, and that's something that we're going to have to engage both with the centre and with you on. And then lastly, we need to actually agree and document what are the features that are going to be available to people at each of those identity levels, 0, 5 and 9, because we want people to be able to sign up, but we also want to encourage them to get to P9. And if you are an existing engaged user, does that mean you come in at 5 or does it mean you come in at 9? So there's actually quite a few things to work through in this process, but I'm quite excited to be able to start working on that in the near future. So as part of the release, we've also been working on taking that invitation process that I talked about right at the start, where the clinician invites the patient, taking that out of the circle of care application and moving it into a new application which we're calling privacy and permissions. And over time, this is going to grow out to be the hub where the consumer can control everything related to who has access to their record. They can invite other members of their circle of care or family to help them. They see what invitations have been sent and whether those invitations have been connected or expired. They can resend them, and they can, on time, get access to an audit trail of who's actually been using the platform once they have signed up. So this is a bit of an animated GIF. This is not a design, it's not real software. This is a conceptual mock-up, this particular slide, of where we're going in the future with this. And we want to introduce this concept of access levels, so people who can only view your record versus people who you trust to contribute to or edit your record. And we're finding that we work increasingly in other places around the world where they have very strict legislation about when someone turns a certain age, so children who are minor becoming old enough to look after their own records, how we actually deal with ending that parental relationship. So we're going to be doing some work on that. And also we're thinking about introducing the ability for patients as they upload data, so shared files, for example, if you want to share a file with a clinician, being able to tag that data as saying it's part of my mental health record, therefore don't share it with XYZ who I've given access to my record because that's a bit sensitive and I don't want everyone to have access to it. So those are some of the areas that we're going to be moving into in the future. And I touched on this very briefly as well. This is another mock-up. The idea behind this is to increase transparency. So showing the patient who has looked at their record, both through the patient portal, but also through the clinical portal. And also through, and importantly, through APIs. So they can see, including break the seal events, why people are looking at their record and what they've done with it. So the last thing that we released as part of 5.12 is a new error and crash reporting framework. And this is provided by a piece of software called Sentry. And previously, if you have used the patient portal and one of your end users ends up in a place where they've managed to crash the app, you would raise a support tracker ticket, and the first thing Orion staff would say is, please try to get that person to reproduce this error and give us a stack trace, and they might use a tool called Fiddler to do that. And that tool gives us access to what happened immediately before the crash happened, and so we can try and figure out why it happened and what went wrong. What Sentry gives us is a much better solution to that problem, so we can get to the root cause of those issues much faster. It allows us to answer questions such as, how actionable is this error? Was it specific to a particular browser or a particular system? Is it only happening to people who have iPhones, for example? And it allows us to see that stack trace that was previously on the user's browser and give that to our development team so they can get to the root cause a lot faster. So this is going to be a really handy feature when you roll out at scale. All right. So one of the best things that we've done in the last 6 months is add a content management system to Engage. And so we've chosen to use a headless CMS. So headless means there is no application user interface to the content management system. If you're familiar with website design, you'll know that a lot of websites are actually backed by a content management system that allows you to add content on the fly. So very easily and quickly, you can go ahead and edit things like the content inside each of these cards, and you can edit pages, you could add news blogs, items, add articles to the Knowledge Hub. So this is really putting that guest website experience into the Engage environment and giving you as customers a lot more control over the content that you see inside the environment, including things like photos. So Kerry will notice and recognise this photo. This is actually from one of the Southern Cross nurses in their uniform. And it allows us to also add things like colour and for you to kind of dictate how that's going to work. So moving then on to another part of the Engage suite, which is our new forms technology. Again, through the work that we did with Southern Cross, we put a lot of new features into our forms capability. And the reason we've been working on this forms capability is because we wanted to put a really modern experience, a responsive UI in front of patients, one that would work on the phone straight away, as well as tablets and laptops. And so we've been creating these little stepper wizards where you can set up your questionnaires or your surveys as different types of pages, and the stepper shows you exactly where you're up to. They can have dynamic show hide rules. We've put calculations in there and repeatable fields. And this allows amazing number of different use cases to suddenly open up your Engage framework, so that not only are you doing the patient part of patient engagement, but you're also doing the pre-patient when you're in that referral phase or you're coming up to a first appointment, as well as the post encounter. So once you've left the hospital, surveys, once you've left your clinic appointment, any follow-ups that the clinician wants to do with you. So this is just a very quick slide on some of the use cases that this new technology allows you to implement. So actually it's available to patients, but it's also available to clinicians. So it can be used by patients through the patient portal, but also if you're a clinician and you have a patient who doesn't have access to a mobile device, you can actually help them fill this in there and then through your clinical portal. And we've also introduced this concept of not logged in. So when I went to have my car serviced, most recs said to me, don't bring the car in until you've filled in this Google form. And I was like, oh, not another Google form. But I went and did it. And this is kind of the same concept. You don't want the overhead of having to set up a user account and log in and look at something. You just want a really quick one-time form that the clinician can email to the patient on the spot to get information. So they might even be sitting in the waiting room. They've just arrived. You want them to verify their demographics, or you want them to check that they haven't moved house, for example. You can very quickly send them this one-time form. They can do it then and there in a browser on their phone, send it back to you, and it immediately becomes visible as part of the patient record. So I'm now just going to quickly highlight some of the benefits of this new technology. So it allows for that rapid exchange of information between patients and clinicians. It allows us to effectively capture that data and put it into our data warehouse so that you can start to report on it straight away. And as I said, for accessibility reasons, it allows patients to engage with that through a wide different range of types of phones and tablets. And here's a couple of examples of what those forms could look like. And as with all Orion technology, it's quite configurable. So you just need to bring the use case to us, the questions that you want on the form. We work through what the rules are, the workflow, and then we pop it into the platform. So it's an example from Ontario where we're currently putting our patient portal and our digital front door in for 14 million people. One of the things we're really interested in with that program of work is equity and accessibility. And so we're going to have a preferences form in their patient portal where the patients can actually tell us, do they ever use a screen reader? Do they ever make the font bigger? And I'm hoping here to be able to, I know it's not related to their clinical care, but I'm hoping that we'll be able to get some insights into the types of people who are using our technology, and we can guide the development of our platform through this information that we collect. So this is what the data looks like once it's actually been saved into the patient record. The patient can tell their story, and this is the example of the standalone patient forms I was telling you about, where the clinician will actually, on the fly, send an email to the patient It can be one or more forms as part of that form pack that the patient's asked to complete. Once they've filled in the data, it appears in the CDB tree right then for the admin teams and the clinicians to action. And that was really the same use case that drove the development of the Southern Cross digital front door, which Kerry introduced this morning. So prior to the pilot that we ran with Southern Cross, the patient would be referred by their specialist to the hospital, and they'd get this paper pack of 13 forms. And there was a lot of duplication on those forms because pretty much everyone started with full name, date of birth, where do you live, who's the GP, and each of those forms would go to different parts of the hospital organisation. And so what patients would actually do is they'd either have to fax the forms back, take a photo of it on their phone and email it, or some people would drive it to the hospital because if they knew they were being operated on tomorrow, they wanted to make sure it got there, or they would post it. And we replaced all of those different channels with a single digital platform. And so they actually saved $12 per pack of forms because they didn't have to print it. So it had a very good financial return on investment of about $400,000 New Zealand annually. But it also made the job a lot easier for the actual admin staff and the clinicians who were trying to consume that information. So one lady said to me, a patient took all the forms, they put them on their kitchen table side by side, and then they got up on a chair and they took a photograph of the entire set of forms, and then they emailed it to me. And I'm trying to transcribe that information into my patient administration system. He forgot to turn them all over and do the back side of all the forms, so I only had half the information, and I had to chase him and ask him to do it all again. So there's numerous benefits around transcription and legibility that come with doing it electronically. So they've had over 500 people go through this process end to end. And as Kerry mentioned earlier, they hit all of their targets, all of the metrics that they set out and their factors for success. They did a fantastic job, and now they're rolling it out across the whole of their hospital network. So this is an example of what some of those forms look like. You can see the name of the form, whether you've started it yet, when it's due, and the goal that they set was to try and get all the forms back at least 7 days before surgery started. And then they've got a very simple touch with your finger to answer the questions with a little note or comment on the side. And we always have a don't know option because patients don't always know how to answer the question. But we also put a little information booklet at the bottom that said, if you get stuck and you don't know how to answer this question, please call this number and one of our team will ring you, help you through that question, and then you can go on to finish the rest of the questionnaire. And of course, within that kind of pre-admission, there's always a big bunch of agreement to treatment or consent forms that need to be filled. And we had great debates as a team about should the patient have to tick every box for every paragraph, or should it just be one tick box? And of course, the user in me says just one tick box is fine. But then the governance person, the lawyers go, well, no, how do we know they actually read them if they don't tick every one? Now, at the end of the day, we probably don't know if they read it anyway. They probably went tick, tick. So part of that process involves asking the patient to tell them on the PHQ, the Patient Health Questionnaire, what medications they're taking. And so on here, you can see we're now starting to pull that data into the home medications review. So as part of your pre-operation triage, the clinicians, the nurses will look at what medications you're on, they'll look at all the different answers in your PHQ, and then they'll decide, do we need to bring that patient in for a pre-op appointment, or are they a simple case and actually we don't need to see them? And so they're, through that, being able to stratify their patients into the complex ones and the simple ones. And for the simple ones, they just go straight to the next step in the pathway, which is 2 days before the operation. The nurse will call the patient and reiterate when to stop drinking, when to stop eating, what meds to stop taking, all of that kind of good stuff. So this is an area that we want to evolve in the next few weeks and months. And we want to actually put an app in the patient's hand, which allows them to create that medication list and feed that into the form. So rather than filling it in a form, you actually create your own app, your own medication list. And then as the patient transitions into hospital, that data would flow into the MedRec process. And then as you leave the hospital and you've got your new medication list, which is curated by the clinician as they discharge you, you can then take home my complete medication list and you know what you're meant to be taking and not taking. And then the last step of that is for patients to be able to say, when they get home, actually, are they taking those drugs? Because not everybody actually takes what they're prescribed. And so we're starting to put scheduling in more from an electronic medication administration record or EMR process point of view, so the clinicians can actually see, did the patient take what they prescribed? This is almost like the holy grail of MedRec, and it is the direction that we want to go long term, is to put the data in the hands of the patient, let them drive the process. So what direction is patient engagement heading in? I've taken you through what we've recently released and a couple of case studies, but before we get there, I want to do a little trip down memory lane. So was anybody here at the 2014 Orion Customer Conference? Yes. Yes, a few of you. So in 2014, that was the year that population health management first entered our lexicon. We started talking about it. We were all trying to figure out what it was. It was kind of happening in the States, and it was kind of filtering its way across the Atlantic. And at that time, we thought these are the factors for success in population health management. I just want you to look at that list and kind of do a bit of a stock take. How many of these have you implemented in your area? Which ones have you done well? Which ones are you not quite there with yet? And which ones have you not even started? Because all of these contribute to doing PHM well. But actually what's happened in the intervening 8 years is quite different to what we thought was going to happen. What's happened, and this is obviously just England I'm talking about now, is we've had massive change in terms of the structure of how we organise ourselves. And this is because we're always on this quest to try and shift towards value-based care. We're trying to figure out how to commission services, how to most effectively deliver those services. So we've gone through and established CCGs, and then we got rid of them, and we established STPs. And if I'm throwing too many acronyms at you and you don't know what these acronyms, please come and see me afterwards. I'm happy to explain them all. Then we moved to light crews, and now we've kind of, on the 1st of July, landed at integrated care systems. Now, this is not a criticism of NHS, because if you look at what's happened around the globe, exactly the same thing has happened. In the US, they created accountable care organisations. And coincidentally, on exactly the same day, 1st of July this year, New Zealand implemented its most massive reform to the healthcare sector in 30 years by disbanding all of the district health boards, and there were 20 of them, creating one national system, and introducing within that one system 4 regions and 80 localities. So the point here is, if you embrace population health management, structural change is inescapable. It's inevitable, it's just going to happen. Secondly, and this is also common across many different jurisdictions, the triple aim became a quintuple aim. So not only did we have to try and reduce the cost of care, improve the patient experience, and improve outcomes, we were also awakened to the realization that the well-being of our staff was critical, and we need to somehow figure out how to close those care gaps and those inequalities, basically do more with less. Now, I doubt the recent statistics would suggest we've made much progress in tackling inequality, partly because of the pandemic, but there are a record number of people sleeping rough on the streets, and there's a record number of people burning out in the healthcare sector, but at least we know that these are important things and we are focused on them. And if you look at the NHS Jobs website, what I found fascinating is how the population health management agenda has started to influence all the different jobs that are being advertised and created. So for example, you can actually see the rough sleepers are a cohort that people are now directly working with. They've realised that in pregnancy, there's a very low uptake of immunisation, so that's another cohort they're trying to improve outcomes in. And there are new teams and new services that are going live all the time in the name of population health management. Here's another few examples. Support for older people, and it's been driven by the long-term plan. Healthcare facilitator, they're just interested in people who take clozapine, lithium, and other mental health drugs. So every single example here points to these targeted interventions and resources being dedicated to those people. But the net outcome of all of that is more fragmentation than ever. And now on top of that, you add the digital first strategy. And here we've got some examples of how that's played out. So this is the Waitless app, which allows you to see your local A&E clinic or urgent care centre and how many minutes you're going to have to wait if you drive there to be treated. This one over here is a really cool game that the elderly people can play when they're trying to rehabilitate through physio. This one's the Red Book for parents, and here's another one that's similar, the Best Buddy app. And then over here we've got the diet and exercise and healthy living kind of app. Now there's just hundreds of these apps, all targeted at particular cohorts of patients. And then on top of that, we get the pandemic. So this is where the majority of the population have been introduced to patient engagement technology en masse at scale. So this is a screenshot from the New Zealand booking system where pretty much everybody who was over the age of 18 was invited to go and book their own appointment to be vaccinated. And then once you'd done that and you'd had the actual vaccine, you could in time go online, set up your COVID record and download your vaccine pass. And I'm sure many of you have had that similar experience. That to me was really good. That was one of the best parts of the COVID pandemic, is seeing that technology adopted at scale. The bad was the fact that my GP practice won't let me actually go and sit in their waiting room anymore. I don't know if you've had this experience, but basically you make an appointment and when the day comes, you turn up in the car park, you sit there in the car, then you phone them and say, I've arrived. And they say, thank you, we'll call you back when we're ready to see you. And then you wait. And you wait, and you wait. And in the meantime, the kids are going berserk in the back seat because you didn't know you were going to wait like this with no access to toys that were previously in the waiting room or books or a TV screen playing cartoons. And that's the ugly bit. These protocols have actually made the patient experience far worse than it ever was before. But let me tell you a little story. This is a picture of where my son is going to go on school camp. And one of the activities they were going to do was the kayaking. Now this camp was actually cancelled because of COVID. The kids were gutted, the parents were gutted. It was the second year in a row that everybody had not been allowed to go to camp. So the parents decided they were actually going to just forget the school's policy and organise a camp for the kids anyway. So they spent 3 or 4 months organising this and everybody fundraised, and I went out and I bought like 100 quid worth of new quick drying clothes because apparently I wasn't allowed to send him with any cotton t-shirts. And then 3 days before they were due to get on the bus and go on their 4-hour trip down to National Park, he started vomiting. And I thought, hopefully he'll get over it by Monday, it'll be all right. Anyway, by Saturday he was worse. So I rat tested him, it was negative, and everyone was like, phew, it's all good, he'll be fine by Monday. But he wasn't getting better. And so basically, over the course of that weekend, it became clear that actually he had got COVID. And I did another rat test on Sunday, and this time it was positive. And I was the nurse who took that test. I was the clinician or the lab technician who actually looked at the results. I was the one who then reported it to the health authorities through the new COVID app that they made available. But when it came to trying to get my refund from the person who runs the camp, they wouldn't take my word for it. They said we need a GP medical certificate. And I'm like, hang on a minute. I'm the one who did all the work here. I diagnosed it, I reported it. The only reason the GP even knows about it is because I told the national system. So something just isn't right about the system anymore. We're starting to put patients in the centre, but we're not really keeping up with changing our processes so that everything can flow naturally around the system. And I rang the practice to try and get a copy of that certificate, and I spoke to a lovely lady who said, I'll put a task in, the nurse will call you back. And then a week later, of course, they hadn't called me back. But by this time, I had COVID myself, so I was so ill, I was like, oh, it can wait, I don't care. But actually, when I felt better, I thought I better ring them back and I'll chase them. I felt like this mum at that point because like I was doing all of the work. And so I decided I should buy myself this t-shirt. And we need to rethink the situation, like collectively, all of us in the room need to rethink as we introduce patient engagement technology. We can't just change a little silo of it. We've got to think the whole process end to end, because if we want patients to be at the centre, we've got to think of that experience from their perspective. So here's an example of a business that has introduced this kind of consumerized self-service model, which is basically what the COVID system was previously, on the previous slide. And I went into a Tesco the other day and I was quite happy to use the self-checkout because I only wanted to buy some innocent smoothies. It's the one thing that I really love that I can't get in New Zealand, so whenever I come back to the UK, I just go and buy one. Anyway, there's this massive raging debate on Twitter. People love them or people hate them. And at this point, I want you to get your phones out because we're now going to have this little debate ourselves. So if you'd like to get your phone out and make sure your data is connected, we're going to go to Mentimeter. So if you browse to menti.com, put in that code, which is 27580675, and then vote. Tell me whether you like self-service checkouts at the supermarket or not. So here are the options that you can answer. You use them as often as possible because you love doing it, it's your preferred way to buy, or you sometimes use them, typically just when you've got a few things and you want to get out the door fast. The third answer is I'll use it whenever it suits me, I'll just join the queue that's the shortest. That's me, by the way. The fourth one is I don't use them very often because I do all my shopping online. I just hate going to the supermarket altogether. The fifth one is I rarely use them, I just avoid them like the plague. And the last one is I never use them. Why should I have to scan and pack my own food? I want the traditional service. I'm happy to queue at a traditional till. I'll just give you a few seconds to do that. Let's see what we got. Interesting, as often as possible. You guys like self-service checkouts? Whenever it suits me is the next biggest option. Okay, I think we have a clear winner. Self-service is really rated by this audience. Now, look at this last part of this Twitter thread. This is the thing I find really interesting. A lot of people don't like them because they've taken out the human element. But for people who have disabilities or this person who's on the autistic spectrum, these things are a godsend because they actually don't want to talk to people. They just want to get their shopping and get out the door again. And that's what the kind of perspective that I want to bring to this role when I do that product director role for patient engagement. I want us to always be thinking about the people who are not like us, the ones who struggle with technology, or they struggle with the whole idea of even being in a room with lots of people. So coming back to kind of where we started, in 2014, this is what we thought we needed for population health management, and here we are in 2022, and this is what we actually got. And we've realised and reached a point where consumerisation has hit healthcare. And I think the pandemic really accelerated that for us. And so what we've ended up with is patients who have access to lots of different IT systems. Now, I could have said exactly the same thing about clinicians 15 or 20 years ago. And we've now gone and put that same mess of disconnected, fragmented apps and systems in front of patients. And this problem is actually a lot harder to solve than the clinician one, because at least with the clinicians, they all work for you and you can kind of mandate what they're going to do to a certain extent. But with patients, they just vote with their feet. They'll use what they want to. You can't be influenced by what browser they choose or what device they bring. You've actually got to give them options. And so the point of that Mentimeter poll was to say, when you do consumer engagement or patient engagement, you've got to give multiple channels, multiple ways for people to engage with it, because everybody's going to engage in a slightly different way, the one that's natural for them. And here we come to the punchline. The irony of population health management is that when it's executed well and it's successful across a wide geography, you actually end up with more disparate than ever services, more fragmentation, more technology being adopted, but then you end up with a new problem, and that is the problem of navigation. How do you physically navigate yourself around the complexity of the health system? Now, just to give you an example from my own perspective on this, this is a roller coaster, obviously. This is the experience that I had recently trying to take my son to a pediatrician. It seems pretty simple. Ring the GP, get an appointment, ask them for referral, book an appointment with the pediatrician, see the pediatrician. I thought that would be simple, but no. I can't book an appointment with my GP because they're not available, so then I'm told, you can have another GP. Okay, that's fine, I'll manage that. Then I was told we'd rather do it as a phone conversation, not in person. Well, that kind of upset me because I wanted to take my child to the appointment, but I wasn't allowed to. But okay, I'll handle that. Then the GP actually organised the appointment, and I thought, great. I had the consultation with them. They said, we'll get you the referral by the end of the day. You'll be able to ring the paediatrician and they'll book an appointment for you. And I was at the top of the roller coaster at this point. I was like, yes, I'm going to get this done in a day. This is great. And then it didn't quite work out that way, because the doctor they referred me to at the practice turned out to not work there anymore. And so they rejected the referral. So when I rang up to say, can I book an appointment with Dr. So-and-so, they said, oh, sorry, but he's gone out to private practice now, and we can't take your referral. So I said, oh, well, give me his phone number for his new clinic, I'll ring them, which I did. But they said, our waiting list is full until Christmas. We won't even take your referral either. So then I'm at the bottom of the roller coaster and I'm thinking I'm going to have to go back to the GP. So I ring the receptionist and I say, I need the GP to call me. And she says, okay. So she puts a task in, and the next day I get a call from the lovely GP who says, your referral was rejected. I was like, I know. And she says, oh, don't worry, I'll refer you to another clinic. So she referred me on. And at this point, I decided it was probably a good thing that the first clinic didn't accept me, because I looked at their pricing, it was $800 an hour. And I was like, oh, good thing I didn't end up at that clinic. Anyway, this process basically went on and on. I went to another one nearby, and then they rejected it because they're full. So I went back to the GP and she said, how about I send you across the Harbour Bridge to the other side of town? They've got a really good paediatrician across there. And so I tried that. Again, played phone tag with the receptionist, couldn't get hold of them, rang them on a Friday afternoon. Turns out they don't work on a Friday. Wait till Monday. It just goes on and on and on. Now the point is, I'm trying to do all this work. I'm trying to navigate my way around the system. I figured out there's like no facilities left in the private sector that have any space until next March. So I go back to the GP and I say, can we please have a referral to the public hospital? And then she drops the bombshell. Oh, I can't send a referral to them unless you've got a hearing test and a sight test, because they'll want to rule those out as problems before they even triage the referral. And I'm like, great, so not only am I at the bottom of the roller coaster, I've virtually gone off the roller coaster, I'm out the park altogether. I'm not even at stage one. I'm like back of the queue to buy my ticket to get back on the theme park altogether. So anyway, you can imagine how I felt when I'd finally managed to get a referral and get as far as talking with someone who could book me a triage appointment, only to get off the plane on Friday afternoon in London and find my husband has sent me a photo of this letter, which I've redacted, that says that they were planning to, if we do not hear from you within 2 weeks, cancel the referral altogether. Now this letter happens to be 7 or 8 days out of date, because by the time they actually posted it, I'd already booked the appointment. So now he's confused. And I said, don't worry about it, it'll all work out fine. But the point is, if we put patient engagement technology into this situation, and that referral had been accepted, a bit like Choose and Book, that clinic could just go, here's a couple of options, pick which one you like, rather than me playing phone tag with them for like a whole week. Now contrast this with the experience that I had when I was in lockdown, probably around August last year. So, and I'm sure this is similar for all of you as well. I had been staring at my computer screen a lot on Teams and Google Meet and the like, and I found my eye was twitching. Has anyone ever had that before? Yeah? Yeah. And I didn't really know what to do about it, but I thought, well, probably best to take my contact lenses out and just give my eyes a real rest. So I basically wore my glasses for a whole week, but that was okay, because we weren't really allowed to leave the house unless we went to the supermarket or the pharmacy, so no one was going to see me. So I did that, and then lo and behold, actually nothing changed. Didn't make it any better. So I thought, okay, well, I've got two options, GP or optometrist, but I don't actually know which one to go to. And then I remembered that we were working with Ontario, and one of the things that Ontario had just implemented was the ADA symptom assessment tool. So I thought, I'll just log onto the test system and I'll try it out. And so I went through the whole symptom assessment, and it asked me all my different symptoms, and I put the answers in, and it got to the end and it said, you don't have to do anything. And I was like, great. And the advice was, relax, stop worrying, it'll go away on its own. And I thought, okay, well, I've got nothing to lose by trying this. So literally I did that. I just stopped worrying about it, and within 24 hours, it had stopped twitching, and it hasn't come back since. And that's what I call patient engagement tools that make a difference. It navigated me, it looked at my symptoms, it navigated me to the right piece of advice. Now, it didn't tell me you have a particular diagnosis of eye strain. It actually said 1 in 5 people with your symptoms have eye strain, and 1 in 5 have this, and 1 in 20 have that. And so I still had to kind of look at, well, there's a possibility it could be serious, but I'll try the most conservative option first and I'll just do nothing. And it was right, it actually helped me. So this is actually a really good example of how the digital front door in Ontario is helping their citizens. What they've done is they've taken a whole lot of navigation and patient engagement technology, and they've brought them all together, wrapped around a 24/7 call centre service. So this is effectively similar to NHS 24 in Scotland or NHS 111 in England. Orion now is responsible for running those services. And we work with a partner who provide the staff. They have about 70 nurses on any one shift at any one point in time. And what it allows them to do is either have a web chat session. So we're offering options to the patient. They don't have to just dial the phone-free number anymore. They can actually start a chat on the website. And they can do their own health assessment through ADA. And when they finish that process, they can go and research in the medical library what those conditions might be and get themselves all ready for a conversation if they decide they do want to talk to a nurse, and then the nurse will actually help them navigate their way around the system. Now this would have been really useful for me when I was trying to find the paediatrician for my son. So these are some of the other services that they run within that call centre. So they've got lactation specialists that help new mums who are learning to breastfeed. If you think you've got colorectal cancer symptoms, you can ring up and request a kit be sent to your home. They have a specific service for refugees. So as people enter the country and they're not connected to a GP and they don't understand how the healthcare system works, they support that cohort. And this is really interesting one around medical assistance in dying. It's kind of euthanasia. So there is legislation in Ontario that allows you to have an assisted death, and they are the starting point for engaging with that program. And then this last one around smoking and vaping cessation is a massive problem. And they are going to, in the future, open up the digital front doors so that people can self-refer into the program and get a quick coach allocated to support them through that journey. So this is the bit where Andrea was going to do the presentation, but essentially how it works is you have the person, the resident of Ontario, they can either phone and connect into the advisor, or they can go to their browser and then they look at what's essentially our patient engagement framework. They call that the digital front door. They're not logging into that system, they're just using it as a website, but we do have plans to introduce that log-on experience as soon as they've sorted out their digital identity strategy. And we've integrated the platform to a CRM, or a contact center software. So every interaction is actually documented through care pathways forms on the clinical portal. And we will be sharing that information, that knowledge back to the patient through Engage once they have logged in. So just a bit of terminology here, the difference between a patient portal and a digital front door, because it's a bit of a new area for some people. So basically the patient portal is traditionally what you log into, and you have a relationship with a provider or a clinician, and you can see your own record. The digital front door, on the other hand, actually offers guests access or anonymous access. Plus, you can become a user of the digital front door, but you're not necessarily yet a patient, or you don't have any active treatment going on, but you can still manage your own healthcare, contribute to your own record. So the patient portal is designed for patients, whereas the digital front door is actually designed for consumers as they go through phases of being a patient and then not being a patient. And as I said, patient portals tend to be targeted at cohorts with specific needs, whereas the reason that you put a digital front door in is to address sustainability of the healthcare system in general. Now, you can include a patient portal as part of a front door, and every kind of implementation of a digital front door or a patient portal will have slightly different value and business cases for it. But really the whole point is the digital front door is the starting point for an interaction with the healthcare system, and hopefully as much as possible that self-service mechanism. Whereas the patient portal is often the place where you actually get things done. And so this is another way of kind of looking at the same information. You've got your whole population here, and traditionally what we like to say is when we're looking at people who are at high risk, we want to stop them jumping into this care coordination cohort where they're more expensive to care for. And we want to identify the people who are in that cohort and give them tools and interventions to make them more part of the general population who are mostly well most of the time. But what you end up doing is basically pushing all sorts of different apps and patient portals in front of that patient. And so the question then becomes, how does all of this fit alongside the national websites that you've already got in place? So for example, nhs.uk or NHS Inform in Scotland. Do you start locally and expect patients will look locally for advice and then maybe jump up to the national system? Or do you think they're going to start nationally and then drill down to your local area? And I think actually the answer is they're going to do both. Some people will come in at one level and go one way, and some will go in the other way. And so what you actually need, and this is kind of what I'm hoping to have a few discussions with you over dinner time, is how do we actually bring this digital front door and fit it into the local context for your local population in the same way that you have your local shared care record for clinicians and your national care records. You're going to have your local Engage and your local DFD linking to the national patient app. So at this point, I was really hoping to do a live demo of what this looks like. This is an example of the digital front door that we released back in April. It's been branded with the NHS colour scheme, and I've kind of linked it to various different parts of the estate. Now, this is an example of what I think it could be, but I'm hoping you guys will be able to tell me over dinner whether you think this concept works, or maybe I'm way off the mark. But essentially, you'll have in your local area, I'm using Dorset here as an example, You have in your local area a pointer or a call to action to the thing that you want your patients to do most frequently. So here I've just given an example of clicking on this button that will take them to NHS 111 online, or telling them that they can call 111. And if you do that on a phone, it will actually call 111, but obviously if you do it on a laptop, it's going to integrate with something like Skype to try and do that call. And then down here you've got various different tools that are available to the patients. And now depending on what you want to promote, these will change. So, and the same tools can be accessed from the menus up the top. And I've given an example here of actually linking out to NHS 111, and it's got its own symptom checker. So there's no real need for us to give you our one. We can just integrate the one you've already got. And the second one is to find a service. So if you're looking for a particular pharmacy or a doctor or urgent care clinic, you can link out to that. So again, I've given an example direct to this is basically jumping from local up to national. The health library is another example, the A to Z. That's exactly what Ontario have done as well. They've put in all this patient information to help you research things. And I've actually used this really often. I don't know if you have ever come across or had friends with diagnosis and you're not really sure how to support them or what that diagnosis means, and so you do a bit of research yourself. That's how I've used it. And then we have the section in the middle where you can include a whole lot of links that point people back to frequently accessed information on their own website. So for example, we've got a link here, so if you want to promote the TPP patient portal, you can do that from here. Or if you want to promote your healthy living program, you can do all of that from here. And then at the bottom, we've got the blog posts, and as I said, with the content management system, your teams can actually create this content locally and add that into the platform on a daily or weekly basis. So you can be really targeted at what you're trying to do with your local population and your communication strategy. And then lastly, at the top there, we've integrated to Amazon Kendra, which is a natural language processing platform, to allow their technology to go and index, a bit like how Google would, a whole lot of different web resources, so that instead of going to Dr. Google, you can actually go to Dr. Orion, and it will filter out all the noise and just show you the resources that your local clinical teams have designated as the best set of resources that your patients should be looking at. So we will go and crawl all the websites that you ask us to crawl, and we'll put those PDFs and those HTML pages into our platform. So you can do some really cool things like depression for firefighters, and it will go and find the websites that talk about that topic. So what's the direction of travel in the next 12 months? So here's a glimpse of the roadmap. We're going to do more with the digital front door. We're going to be introducing caching. We're going to be introducing this concept of request a callback. So rather than actually phoning 811 in Ontario or what would be in NHS 111 here, the patient can go on the website and say, please phone me back, and they'll go into the queue in the same way that they would have if they'd rung up. We're going to be replacing our open LDAP technology, which is what we store user accounts with this technology called KeyCloak, and that's going to enable us to do the NHS logon integration. And then we're also going to be working with our Spanish colleagues who are sitting at the back there to do a pilot where we bring data in from Apple HealthKit and Google, so we can start to sync steps and activity and heart, blood pressure, things that the patient is recording on their phone into their record, and that's really exciting as well. And as I said earlier, we've got a massive program of work set up for the patient portal. We're looking at the audit log. We're hoping to rebuild some of the dashboard widgets and extending patient registration. And then I'll just draw your attention also to, we're going to be reworking the lab results and introducing graphing and trending into that, because it's a feature that patients have told us they really like to see. So we're at the end. Hopefully I've unpacked for you now what patient engagement is, what we've been working on, where we're going. And of course the irony of population health management is it's created more fragmentation. And we're now in a situation like we were with clinicians where we're putting this mess in front of patients. And what we're doing at Orion to respond to that is we're moving from viewing the records to lots more doing tools. You've seen that with our forms technology, with the MedRec vision that we have. And we're bringing that guest and that logged in user experience much closer together, so there's a real transition from one state to another state and back again to really be able to offer a holistic experience for you as citizens. And that's a wrap. Thank you very much.